such a fantastic lineup of speakers today. It's going to be a great day. By chance, did you know that it is National Cheeseburger Day? You did know that. Joe, Mark, are we having cheeseburgers today? No, we're not. Good night. Okay. Well, folks, we're ready to get started on our next presentation. Dr. Martha Leatherman is here. She's going to be talking about assessing the competency of patients with Alzheimer's disease. I had the opportunity to meet Dr. Leatherman not here in San Antonio the first time, but she was presenting her training program at a National Alzheimer's Association conference in Chicago many moons ago. So it was neat to see a fellow San Antonian in Chicago representing. So I did want to let you know a little bit about Dr. Leatherman. Dr. Martha Leatherman is a board-certified physician in psychiatry with a board subspecialization in geriatric psychiatry. Dr. Leatherman has been practicing medicine as a geriatric psychiatrist since the early 1990s. She sees patients in an office setting and additionally has considerable experience evaluating people for consideration for guardianship, as well as doing retrospective analysis of medical and life records to determine testamentary capacity. I was working on that word, testamentary capacity. Can you all please help me welcome Dr. Martha Leatherman?
See if, now, does that work? They ask me, are you a stander or a roamer? And I think I'm a roamer. Well, this is sort of a difficult talk to get my mind around because the team wanted particularly to talk about Alzheimer's disease. And in order to talk particularly about Alzheimer's disease, we have to understand some biology. And I am a physician and sort of a neurochemist, and I really like biology. So hang on. We'll get through that part fast, but you need to know it. At the same time, we've looked at psychological and legal, we're looking at medical perspectives on a geriatric capacity examination. And I'm looking at it from a psychiatric point of view. And so often I'm asked, what's the difference between a psychologist and a psychiatrist? Well, a psychiatrist is a medical doctor. I go through residency and internship and surgical training and the whole thing like any other MD, and then go on for extra training in psychiatry, which is the medical aspect of brain diseases. Now, I have been challenged on this before, but I'm going to keep this slide and use it. Helen said that the title of my talk was about a competency exam. We're taught in medical school, and it's dogma, that competency is a legal determination, whereas capacity is a medical determination. And this is way back from the 1980s. We could quibble over that, but what I want to point out is that as physicians, what we are looking at is somebody's cognitive, psychological, mental, and psychiatric capabilities, not necessarily the law of that. And I think Dr. Trey Russell Thompson did a good job explaining that earlier today. But so sometimes, especially if you're dealing with a trainee, a resident, or an intern, and you say, we need a competency exam, they might look at you and say, we do capacity examinations, and just that's a little bit of a historical thing about that. So I'm going to be talking about capacity. Now, the thing about the capacity examination is that it is not a clinical examination. And I will say that when I get a call from somebody saying, can you see Mr. Smith? We think he's got some problems. We're looking at a guardianship. and some of the attorneys here might really want to challenge me on it. I say, do you have an attorney ad litem? Do you have a guardian ad litem? Do you have a court order? Because if you're sending somebody to me assuming that they lack some capacity, how can they consent to my exam? If they don't consent to my exam, it's sort of like, you know, asking a 4-year-old, hey, can I do a gynecological exam on you? You got to have an agent allowing you to kind of get in somebody's head if they don't have capacity. So that's ethically sort of a very important thing to me, and so anybody who doesn't like it, you know, we can talk about it, but that's why I do it. Because it really isn't, I'm not going to be treating these people. It has a different purpose, which is perhaps to take away their liberty, not necessarily to help fix their anxiety. We use different data. You know, it's not common when somebody comes in and says that they want to be treated for depression for me to look at their financial records or to talk to their next door neighbors or to talk to all their children unless they invite them in. But I need that data. So we look at different data sets. It's a different technique. And at the risk of sounding a little bit, I don't know, not nice. It's sort of a gotcha technique. I'm looking for areas of diminished capacity, for diminished cognition. I may know a whole lot of information about what happened in the last 6 months with that person, and I ask them questions. Where are you living? How's it going? So often, if I have a family member or sometimes an attorney who has never worked with me before sitting behind the patient, and the patient's in an assisted living, and I say, where do you live? Oh, I live at 438 Down Street. I've lived there for 20 years. And the person behind me is going, I know that. It's part of the exam. So I'm really using a very different technique than I would in a clinical exam. My index of suspicion is high. They wouldn't be there if it weren't. My index of suspicion for cognitive impairment is high. And I would say about 30% of people I see, family or the attorney will come in and say, she can fool you. She looks fine on exam. I know that. Everybody who comes in, I'm expecting to try to fool me. Now, it doesn't mean I can't be fooled, but, and I'm going to talk a little bit later about how we can be fooled and how I work around that. But I do have a high index of suspicion for cognitive incapacity where we don't always do that in a psychiatric examination for clinical purposes. And finally, there's no confidentiality presumed. You know, I'm going to have to talk to the attorneys, I'm going to have to talk to the judge, and we are required to tell the proposed ward in this kind of examination for a guardianship that it's not like your regular doctor-patient relationship, that I can share this stuff and I have to share this stuff. So that's just kind of walking into it. Now, what am I looking for? I mean, people are typically incapacitated because of dementia of some sort. But there can be other things. I mean, I've certainly had, and have had in common with Dr. Tierney here, patients who were profoundly incapacitated due to depression. Now, if you can't get out of bed and you can't take a bath and you can't feed yourself because you're so depressed, this is an incapacity. So we're looking at all of those things. We're looking at, does a psychiatric diagnosis impact a cognitive diagnosis? So the first thing we do is we look at the symptoms that the person has and identify them. Are they amotivated? Is that because they're depressed or because they have a neurological problem? Do they have a tremor? Is that because they have Parkinson's or because they're anxious? So you identify the symptoms. Then, and this is kind of where the art and the medicine of it come through, you identify the cause of those symptoms. And that's basically a diagnosis. Most commonly, I see dementia. And Alzheimer's is one form of dementia. And I'm going to step outside the sort of regular kind of medical discussion of Alzheimer's. One has to question at this point in 2014, what is Alzheimer's anymore? You know, Alzheimer's used to be, you had to have a brain biopsy to diagnose it clearly and definitively. Then it became a clinical exam, and now they're saying, well, because people, and we'll talk about this a little bit later, have plaques and tangles when they have senile dementia, like in their 80s, we're going to call it Alzheimer's. Well, clinically, the old Alzheimer's, the real malignant form that came in people's 50s and 60s, and the kinds that Dr. Alzheimer described, is different from the senility that we see now, but we're calling everything Alzheimer's. And it makes you wonder, are we going to miss a cure for it because we're lumping everybody with aging brains in and calling it Alzheimer's? So when we talk about Alzheimer's and kinds of dementia, you have to say, well, what really is Alzheimer's? Is it just memory loss and you're old and you happen to have some plaques and tangles, or is it the real deal? There's vascular dementia, and I'm going to tell you a little bit later how that can look very much like Alzheimer's and how the pathways converge, and they may be very similar illnesses, especially in late life. Because if you think about it, as our bodies age, our brains age too. Things fall apart. If your brain is falling apart and the connections aren't being made, you're going to have cognitive problems. Like if your knee falls apart and it's not making the connections, you're going to have physical and mobility problems. So it's connected to a physical problem, and if you've got vascular dementia, you can really overlap and look like Alzheimer's. So that's another problem with kind of talking about capacity in Alzheimer's, is we got to wonder, what is Alzheimer's? Toxic, high digitalis levels, drug abuse, coming more and more often in elders now because many of them were swinging in the 60s and 70s, and that lifestyle has persisted. Prescription medications are way a big problem with people. So are we seeing some kind of toxic process, or what we call organic? You know, do you have a space-occupying lesion? Do you have a thyroid disorder? Or do you have a hepatic disorder? Have you had a hip fracture? And I remember a fellow out of Comal County, and it was all the way to a jury trial on a guardianship because the neuropsych testing had showed that he was absolutely demented. The 3 doctors in the rehab after his hip fracture, absolute dementia. Well, I saw him and he had been delirious and cleared. But nobody had seen him except me after he cleared. So he just about got a guardianship. Now, and he was 94. So everybody said there was sort of an ageism. Of course. We got 3 docs and a neuropsychologist and the family saying that this is dementia. But he did clear, and actually, that was about 3 years ago. He is still living independently and managing his affairs. So you've got to be careful about reversible causes of dementia. And the other thing is the DSM. And I will say that we have to watch out because the DSM itself says that the specific diagnostic criteria included in DSM are meant to serve as guidelines to be informed by clinical judgment, which takes some experience and training, and are not meant to be used in a cookbook fashion. And again, you know, on the stand, are you telling me, doctor, that, you know, I'm reading all these symptoms and this patient doesn't have bipolar disorder? Well, yeah, because you can't use it in a cookbook fashion. The other thing that DSM says is that these criteria and things are meant to be employed by people who have the appropriate clinical training because histrionic is something different than mood swings, or manic means something different with training, and that's what the DSM means, than somebody who says highly excitable. my mom's manic all the time, using it as highly excitable, or mood swings. Clinicians mean something different by mood swings than the lay public does. And for this purpose, that there's an imperfect fit between the questions of ultimate concern to the law and the information contained in a clinical diagnosis. And I'm going to talk about that a little bit later, because I did add some slides and some information about testamentary capacity. So this is your brain. It's not your brain. It's not even my brain. It's a schematic of a brain. And it's looking this way. So that's the front. And you have all these lobes, and they do all different kinds of things. We have the frontal lobes, and when we talk about executive impairment, that's what we're really talking about, the frontal lobes up here. The cerebellum, which we're finding out does a lot of work we didn't think it did before. That's the temporal lobe, the parietal lobe. So each of these lobes does some sort of different things. The temporal lobe is involved with memory and emotion. The occipital lobe at the back is involved with vision. The frontal lobe is involved with executive function, insight, and judgment. But they're all connected. They don't act in isolation. So if you have frontal lobe dysfunction, and here's your frontal lobe, if you've got frontal lobe dysfunction, you're going to have problems in the occipital lobe because of the connections. So that's the thing you have to remember, is the connectedness of the brain. Talk a lot about executive function. I'm going to fly through it real fast. It involves planning, initiation. I'm hungry, and I sit in my chair and I don't get up to get something to eat. Part of executive function is what I call the go button. They can sit there all day and say, I'm hungry, I'm hungry, I'm hungry, but unless somebody initiates it for them, they may not be able to do it, which is why better residences and facilities allow the staff to eat with the Alzheimer's patients, because that cueing can initiate the action for them of eating. Sequencing, and we're going to talk about this a little bit later again too. So if I need to make a sandwich, I have to get up, I have to know what's in the house, I have to decide to make the sandwich, I have to get it out of the refrigerator, figuring out that sequence. And then following through. Stopping doing something. You see a lot of repetitive vocalizations, movements, questions. You've got a go button and a stop button in the frontal lobes that tell the brain to turn on and turn off. Executive function is involved with memory, and I'm not going to go into that a lot. Judgment. You know, how much about your personal medical history do you tell at a party? How much about your family's personal medical history do you tell a group of strangers? Where is the judgment in how you interact with people? Do you say, oh, look at the ugly person? No. You have better judgment. Do you, when a nicely dressed young man comes to your front door and says, I'm from the Social Security Administration and I need all your information so we can make sure that you get all the benefits you deserve, do you have the judgment to know that that might be a scam? And this is where it gets dangerous, because you can ask a person, you can say, now, if somebody came to your front door and said, give me your Social Security information, I want to make sure you get all your benefits, they would say, I absolutely would not do that. I know better than that. That's a scam. But when it happens, they can't connect what they know they should do with what they actually do, especially if it's a nicely dressed young man. So judgment is a part of executive function, reasoning and logic. Shifting sets and flexibility, and sometimes that's one of the earliest things, is the inability, the inability to quickly move from one set to another. And Dr. Thompson was talking about the 1A, 2V, 3C, 4D thing. That's a set shifting test. And clearly it's affected by language, which is where the art comes in, because if you're going to follow a straight protocol of neuropsych testing and just dump a bunch of data in a colander and have it come out and give you a diagnosis, as he pointed out, you lose the art. If you've got a language problem, then you've got to figure out some other way. And it may be clinical to test set shifting. And so very often my patients and the families think that I'm just chatting with the patient, when in reality I'm testing because I'm shifting sets. We might be talking about finances, and I'll say, tell me about your dog. And if they say, well, you know, the vet bill, I'm saying, oh, there's a little trouble with shifting sets there because they're staying on finances. So that's another executive function. Inhibition, the hand over the mouth. Do not do this in public. And people with dementia and Alzheimer's and executive function problems have trouble with inhibition. Awareness, safety awareness, but mostly awareness of their deficits. Classically, Alzheimer's patients have no awareness of their deficits. They think they're just fine, which is why you know, it's hard to take the keys away. And then interpretation of people around you and events around you and putting them into perspective to make decisions on them. So, what is Alzheimer's disease? It's not necessarily just a memory disorder. We have the picture of the brain. It's all connected. Those lobes are all connected. We have cognitive and behavioral problems with it because all of those lobes are affected. It's a set of symptoms. And typically it begins here in what we call the hippocampal region. And early on, the disease, you see, let me see if I can point, right there. See right there? That's a little bit spacey. There's a little bit too much space there. The neurons are dying in those areas. As the disease progresses, you can see more spaces, and the spaces opening up wider and wider in that other slice of the brain. The top one is a slice of the brain this way, and showing the death of the neurons and how the spaces enlarge as the disease progresses. And so ultimately you have kind of a Swiss cheese brain. And when I look at medical records and I see radiological reports that say normal atrophy associated with aging, what's normal? Is that normal? Not really. I mean, it may be typical, but it's not normal. You got to have those brain cells in order to use your brain. So yeah, atrophy is a big deal. But the disease sort of spreads from this immediate memory problem to the frontal lobes and then ultimately overtakes the whole brain. So that's part of the progression of classic Alzheimer's. The hallmarks are prominent memory loss, but more important to me clinically is that the memory doesn't stick. And I don't know, I think in pictures, you throw it at a wall and it just doesn't stay up there. So on the mini mental status examination, I want you to remember 3 words: piano, hippopotamus, and the color blue. Now say them back to me. Piano, hippopotamus, blue. Spell the word world, W-O-R-L-D. Now spell it backwards. Spell it backwards. What were the 3 words? Okay, one of them was a musical instrument. Oh, piano. Good. One of them was, and now this is not classically how you're supposed to do the mini mental status examination, but this is the difference between clinical and sort of classical programmatic testing and why the art of it is important. What's the second was an animal. Oh yeah, hippopotamus. Now that is not memory that doesn't stick. That is memory that needs a prompt for the recall. An Alzheimer's patient say, okay, what were the 3 words? One of them was a musical instrument. Trombone? Just guessing, just guessing. They can't remember, it never registered. So that's sort of one of the classic things that you will see in Alzheimer's, which means that you cannot learn new things. The most important thing about the memory loss is that you cannot learn new things. How can you learn it if it doesn't stick? So your wife is dead. Where's Marjorie? Your wife is dead. You can't learn it. Okay? And also a huge, because of the frontal lobe involvement, the lack of awareness and insight. I am fine. I have no memory loss at all. And it's, of course, progressive, as we know. So if you have a bunch of little strokes all over your brain, could that look like Alzheimer's? Here's a hint, yeah. Because what you're doing is you're killing brain cells throughout the brain, throughout the cerebral cortex, and impairing those connections between the areas of the brain. So this is why if you've got a brain on an 89-year-old person that is already fragile, you've already got some neuron loss, some nerve cell loss, and you start having dings, strokes, you can get a global dysfunction that does look like Alzheimer's. The other interesting thing about this, I don't know what that's doing. The other interesting thing about it is that when you start getting those dings and strokes, you get inflammatory processes in the brain, which then create amyloid plaques. So which came first, the chicken or the egg? So these plaques and tangles are really not pathognomonic, they're not diagnostic. So what is not? Medications. I have cured many people from Benadryl-induced Alzheimer's. Anticholinergic medications, Benadryl is a biggie. Diphenhydramine is the generic name of it. The other one is the bladder control medications because they have the same mechanism of action. It's almost a chemical Alzheimer's. So you always have to ask, is the thing helping? Or do we just have you on it because somebody said you had incontinence and somebody threw it at you? Pain medications, huge cognitive impairment with that. Depression, and we talk about the pseudo-dementia of depression, and as Dr. Tierney likes to talk about, the pseudo-depression of dementia. You get an early sort of depression and dementia combination. Which is it? Is it early dementia or is it depression looking like dementia? And sometimes you can only tell by waiting, just time. And delirium, which we talked about a little bit earlier. Talked about organic. Thyroid is a big one. That's not what you think it is. That's space-occupying lesion, which may be the same thing depending on what it is. Now, see, that was a little disinhibited on my part. If I hadn't caught it and I had kept going, you might want to say, she's a little bit disinhibited. Urinary tract infection, huge, and people are finally catching on to this. And my favorite, my husband's an internist, so I can say the internist stuff. She has no clinical indication of urinary tract infection. Yeah, well, the delirium might be one. Maybe not fever, maybe not pain, but maybe the delirium. So you got to treat the urinary tract infections because for whatever reason that I don't understand, a lot of times elders will have profound urinary tract infections and no pain, no fever, and minimal white counts. I think that the aging body is kind of like an infant body in that it doesn't mount a really strong immune response. So a lot of times babies, when they're very sick and have a bacterial infection, their white count will actually drop instead of go up. And my theory is that elders do that too. Dehydration is another big one. Diabetes, all the things that affect the brain. Because the brain is the canary in the mine shaft of the body. The thing that the brain in an elder is fragile, and the things that will make your body sick, the brain will pick that up first and show it symptomatically first. So, what's an adequate neuropsychological evaluation? Medical records, history from the patient, collateral history, but more important, the tests are only as important as the training of the person interpreting them. And I think that neuropsychologists really ought to give their own tests and not give them out to clerks to give the tests and then interpret them, because you learn so much from watching the patient take the test. The other thing is that the test cannot be used in isolation. There's sort of a famous case with sort of a famous neuropsychologist, and they sort of lost because he had none of the collateral information and relied on the person who's going to write this will to tell him about his life. And so he told him about all of his life in Killarney, Ireland, and, or was it Limerick, Ireland? Anyway, Ireland, and that he'd been a fighter pilot and yada, yada, yada. The tests came out great. The day before the will signed, the tests were great. But when we got on the stand and kind of said, he was born in LaGrange, not Ireland. He was just confabulating. He was making all of this up, but the tests looked fine. So you can't look at them in isolation. And a normal score can be misleading, and an abnormal score can be misleading. We've looked at the MMSE. I think Dr. Thompson talked about it a little bit. You know, if somebody has been in a rehab facility for 5 weeks undergoing rehab for hip fracture, they just might not know the date. Now, does that mean they're demented? Not necessarily, but you can surely get a lot of dings from that. If they're debilitated and weak and can't draw the pentagrams, do you get a ding for that? But the other thing is you can have a perfect MMSE and be profoundly demented with frontal lobe dementia and have no executive function. So, because this really does not test executive function. So you have to be careful about that. For example, which clock is, trick question, diagnostic of the patient with dementia? Did somebody say the right one? That's a trick question, neither one of them. Neither one of them. You could have frontal lobe dementia and draw this clock perfectly. You could even have early Alzheimer's and draw that clock perfectly. You could have visual impairment and perfectly intact cognition and draw this clock. So that's the point. There's no diagnostic test. No test in isolation. So, as I look at a capacity in somebody, I'm looking at medications, medical records, labs if I can get them, and any psychiatric history. But I'm also looking at the social and the situational information. Are they home alone? Have they been isolated and alone for a long time? Would just some structure of having people around improve the cognition? Because anybody can go, I mean, you hear cabin fever. You can go stir crazy sitting by yourself in a house or a cabin for a long time and not think clearly. And there are great movies made about that. So you have to look at all of that as well. The medical diagnosis that we give is sort of an objective thing. Have elevated white count, mass in your lung, fever, cough, and sputum production. The objective evidence says that this is pneumonia. But what I'm being asked in a capacity examination for guardianship is opinionative, which I think I made up. In my opinion, does the intellectual dysfunction or the cognitive dysfunction impair the patient so that they can't perform X, Y, or Z tasks? Now, sometimes I have information about tasks they cannot perform, but sometimes I have to look at the cognitive function and project and predict whether or not. And the difference between speculation and prediction is what cross-examination is all about. But we are using our experience and our insight and our knowledge and so forth to make a prediction to help the court. You know, my role is to be there for the court to help them make the determination about a guardianship, because they will hear information that I might not hear. They see things that I don't see, and they know a lot of law that I don't know. The other thing is, and this is, I think Kelly Cross is the other person running today for probate judge, besides Barbie. This is Kelly's favorite slide. Cognition and capacity is not a finite attribute. It changes with the complexity of the task. So to sit on the toilet requires lots less cognition than to devise a trust. So with more complex tasks, you need more capacity. The other thing is, as we're looking at a guardianship and competency, is the capacity, if you're asking me, can this person continue to run a medical practice and do surgery versus can he make decisions about when to eat, then I need more information to do the exam. I need to know what his medical practice is about. I'm involved with the Texas State Board of Medical Examiners on impaired physicians, and it's a growing concern with physicians who have cognitive impairment. And the sort of reflex answer is, no, cognitively impaired can't do anything. Well, there's a lot of old learning involved in medical practice. There's a lot of just sort of rote stuff that we do, and with a supervisor, this person may be able to practice, but you have to know what the situation is in order to determine the level of complexity. Actually, I was wrong. This is Kelly's favorite slide. Judge Spencer said earlier today that testamentary capacity is a lower standard than something like contracting or independent living and financial. And this is true by the literature. However, so often testamentary capacity involves knowing all kinds of complicated stock and bond and investments, multiple family relationships with marriages and remarriages and stepchildren and step-grandchildren, half brothers and sisters, trusts. Now, when I read trusts and I say, okay, this person is the trustee and also the beneficiary of the trust, and who's the successor trustee, that's a little bit more than knowing I want my kids to be taken care of. So, you got to look at what we're talking about with testamentary capacity. Is it a simple will where, dad and mom have the house, they want to sell the house, divide it up equally among the kids, versus all kinds of trust documents? So, again, typically testamentary capacity is put low, but I really would argue that the medical field is, well, the legal field hasn't really quite caught up with medicine and science on that, because there's a lot more involved in making a lot of wills. So let's talk about testamentary capacity. And I like schematics, and so I'm always trying to explain to juries why it's important to have memory, because lots of experts will say he has mild memory impairment or he has moderate memory impairment, but he knows in general what he wants to do. So here's the task. What we want to do is get those 4 little boxes over into the task place, and it has to go through the memory. So normally we're just going to send them over, we're going to fill that in, boom, you made a will. Good, it went through. Now what happens if you lose memory? So as you're trying to get things over into the box to do the task, it just falls out the bottom. So in order to make this will, you've got to be able to remember, I've got 4 children. I'm in business with one of them. I have an overflow trust with a successor generation something. Patty Schnitzler is going like this. And I already bequeathed a huge sum of money to my daughter 3 years ago to buy a business. You've got to remember all of that in order to make a fair will. But if that memory's not there, what's the person going to do? Well, he might decide to ask for some help. Or somebody might come in and say, I can help you with that. Look, here are the pieces that you need. Your daughter never comes to visit you. You never gave me anything. They've done away with you. They don't really care about you. They say bad things about you. So the person doesn't have their own memory. They have memory substituted by somebody else. And my understanding, and I am not a lawyer, my understanding is that, I guess up until a couple of years ago, Texas law, and maybe other law as well, says that in order to be unduly influenced, you have to have testamentary capacity. Medically, that is not true. Because if somebody else is supplying the information to make the will, and you don't have enough capacity or memory to know that, then they're substituting their judgment for yours. So in fact, the less capacity you have, the insight, the judgment, the reasoning, the sequencing, all of those frontal lobe functions, the less of that you have, the more vulnerable you are to undue influence. So then we talk about, and testamentary capacity is the ability to make a will. I didn't say that, but I figured y'all knew it. The myth of the lucid interval. But that moment that he made the will, he was lucid. Well, actually, there's no medical literature about the lucid interval in terms of dementia. And if I'm wrong, I'll do the next one of these for free. By the way, I'm doing this one for free. No, it's not found in the medical literature. It's talked about in terms of schizophrenia and psychotic illnesses. So for 3 months, a lady believes that she's controlled by the Martians and she has to wear the aluminum foil hat because they're making her eat certain things. That psychosis clears. She didn't lose her ability to think and have cognition or memory during that time, but she was influenced by the delusions. So the lucid interval is when the delusions go away. So it's a huge legal leap to talk about a lucid interval with dementing illnesses. Okay, good days and bad days. Here's the other argument. Well, she has good days and bad days, and everybody knows. It's on the Alzheimer's Association website. There are good days and bad days. We all know that. Yeah, what do you mean by good days and bad? Are you doing cognitive testing on good days and bad days? Or are you just saying she's calmer, or seems to be more interactive, or maybe a little bit more alert? So what does a good day mean? Let's go all the way and say that on a good day, the memory is 100% preserved. They can learn new things on that day. Can they remember what happened 3 months ago when they weren't having a good day? So you have to be able to put all of those things together. So when you're talking about a lucid interval, you have to know what you're really trying to say. What's lucid? Are you talking about cognition or behavior or delusions or psychosis? And how does that fold into all of the historical things that may have happened when you weren't having a good day and you weren't remembering things? So you can see why I'm not sure that I really agree with the law that testamentary capacity is such a low threshold for decision making, especially when we're talking about complicated estates, family situations, emotional situations and dynamics, and legal documents. However, it is true that capacity is not a finite attribute. There are different levels of capacity that are necessary for different things. So when I look at a will contest case, I want to read the wills. I want to know, and the trust documents. I want to know what's going on. Financial stuff is very difficult. You know, you might be able to do the math, but can you get up off the couch to get the bills to the post office? You know, so often we'll have families say, look, I organize all of her bills on the table, and I come back, and the next week they're just sitting there. Well, that executive function, she doesn't have the go button to be able to get that task initiated. So knowing your finances and actually being able to do it are two different things. That got out of order. Never mind. I'll just let you watch that. So that's the broad overview. I don't have a watch or a clock, so I don't know what time it is, but if I've got time for questions, I'll be glad. I have 10 minutes for questions. Oh, I did such a good job. Oh, come on, surely somebody's got a question.
Oh, wait, we do have one. Here's a question in the back.
Okay.
Would you speak a little bit more? You said lots of lab work, lots of lab work. Would you speak a little bit to that when you said lab? Does that question make sense?
Well, looking at, if I'm making a clinical diagnosis of Alzheimer's, I want to know, is the person anemic? Do they have an infection? Do they have a urinary tract infection? So I'm looking at urine. Do they have thyroid disorder? Because that can really dull cognition. So I want to know that medically there isn't some compelling reason for the cognitive dysfunction that people are seeing. And so that's what I mean by the lab work and needing to get it. And either I'll get it or work with the internist. B12 is another one. B12 is probably one of the few, B12 deficiency is one of the few truly reversible causes of dementia. And so you really always want to look at that level as well. In terms of will contest and testamentary capacity, I have to look at the labs at the time the person was making the will. In guardianship cases, a lot of times what I'll do is I'll say, there's cognitive impairment, but I don't have any medical records, or I don't have sufficient medical records. If we address X, Y, and Z, we might want to re-examine them in 6 months and see if the cognition has improved, because just the smell of this thing is kind of wrong. It doesn't seem typical, and it could be other things. Did that answer your question? Yes. Okay.
Could you clarify the capacity and the difference between that and competency?
Well, I can tell you that as physicians, we are taught that we don't do competency exams, that's a legal determination. And again, that was just sort of dogma about what we were taught. I think Judge Spencer could probably answer it better legally. Again, I was challenged on that in a few years ago, where an attorney said, oh no, attorneys determine capacity all the time. And I think the point that I'm trying to make is that sometimes you might ask a doctor to do a competency exam and they'll say, well, I'll do capacity. And to give you some understanding of maybe why they're coming from that position. But the other thing is that I am, and I think this is the bottom line, I am looking at the person's capacity to carry out certain functions necessary based on their cognitive examination or deficits. Okay? Other questions? Oh, there's one back there.
Oh, okay.
You said you get a court order, et cetera, before you do a capacity eval. What do you do, or what are your recommendations for inpatient requests for capacity evals?
Well, it depends. I'm talking about for guardianships. So is that what you're talking about?
No, just capacity evals. So if it's just a capacity eval, you're okay without getting all those box checked off then?
Well, for what?
It depends.
Right. So, and she said it depends, and it does. So if it's the capacity to make the treatment decision and there is a power of attorney in place already, no, I don't think you need the court order. But see, a guardianship, that person becomes, with a full guardianship, becomes as a child. And once you're under a full guardianship, you can't go hire an attorney. You can't write a check to challenge it, so you're stuck. So my threshold for getting into somebody's brain and examining them is very, very high with that. And I want to make sure I have the court looking at me, and I want an advocate watching for the patient watching the process too. Okay, I guess we can finish early then. Thank you.
Thank you.
Valiente y te vi